Hello, everyone, and welcome to this evening's presentation where we're going to be discussing the functional medicine approach to weight loss resistance. For those of you who don't know me, my name is Dr. Breanne Kallonen. I'm a naturopathic and functional medicine doctor, and I help individuals get to the root cause of their resistant weight loss, low energy, and hormone-related concerns. What we're going to cover today is how I approach functional weight loss in my practice. We're going to cover things like hormones, detoxification, blood sugar imbalances, gut health, and how this relates to your metabolism. Of course, stress, the hormone cortisol plays a role, thyroid function, genetics, as well as navigating the terrain with GLP-1s or semaglutide-based medications, which have ever so grown in popularity. Who am I? Again, Dr. Breanne Kallonen. I'm a naturopathic doctor. I'm also a mom of two. I have private practices in Ontario and Saskatchewan. I've written a book called Wild and Free, which is a best-selling book on Amazon. I'm the creator of the Metabolic Reset Program and the founder of Wildside Wellness. What is the reality that we are facing? The reality today is that the probability of achieving normal weight loss with simply telling our patients to eat less and move more is about 0.6%. That is a 99% failure rate, 99.4% failure rate if all we are doing to educate individuals, which I know we're as naturopathic and functional medicine doctors doing so much more than that. But this was a huge surprise for me in this study, 99.4% failure rate if physicians are simply telling their patients, go ahead, move more, eat less. So we know that the problem is widespread. 64% of Canadian adults over the age of 18 are overweight and obese. This really alarms me as a mom of two developing children. 30% of children aged 5 to 17 are overweight or obese. 7.3% of Canadian aged 12 and over are diagnosed with diabetes, which is alarming. 25% of adults are considered to have metabolic syndrome, and these rates are ever growing. And while we cannot change risk factors such as your genetics, your family history, your age, your ethnicity, one can absolutely change lifestyle risk factors such as diet, lifestyle, exercise through modulation with nutraceuticals and pharmaceuticals and diet and lifestyle. There's so many ways that we can support our patients. Now, when it comes to weight loss, I see weight loss resistance or weight gain as merely a symptom, the same way that I would see anxiety, depression, diarrhea, constipation. Those are symptoms of something else going underneath. So we need to evaluate the GI, the liver. Is there inflammation? Is there insulin resistance? Is there oxidative stress? What is that underlying cause? Because diet and lifestyle is just one small piece of the puzzle. There could be GI infections, toxins, sleep issues, exercise issues, nutrient deficiencies, which we're going to cover in detail today. Section 1, blood sugar imbalances and insulin resistance. This is a big one and one of the most common things that I see in my practice. Very few individuals in North America are truly metabolically healthy, and there's some studies that are estimating 1 in 3 and 1 in 2 individuals actually have insulin resistance if we diagnose it properly. So what is insulin resistance and how it develops? Insulin resistance, you can have a genetic predisposition to it. You can have stress and cortisol raising your blood sugar over time, leading to insulin resistance. Lack of muscle mass is a huge one. Nutrient deficiencies. We are now seeing new studies that are showing gut bacteria imbalances can contribute to insulin resistance. And then, of course, diet, the overconsumption of hyperpalatable, hyperprocessed foods. This is an important slide. This you can find on Google. You can screenshot it here. This is exactly how I explain what insulin resistance is to patients. I think one of the hurdles that needs to be overcome when talking with patients with respect to weight loss is helping them to truly understand what's going on, because the more our patients are educated on why this is happening, why they are feeling a certain way, the more likely they are to be, at least in my experience, to be compliant with the treatment plan. So when you eat carbohydrates, those carbohydrates are broken down into glucose, and it doesn't matter what type of carbohydrate it is, whether you eat fruits and vegetables, cake and cookies, they're all going to be broken down into glucose, and this results in a rise in glucose in the blood sugar. That's what those red squares are. Once you have glucose available in the bloodstream, that's going to signal to the pancreas. And again, I show these slides to patients. That's going to signal a rise in insulin. And insulin is shown here as the key. And the role of insulin is to help open the door on the outside of the cell so the sugar can get in. We want the sugars to get into our cells so that we feel good, so we have good energy, so we can think, so our muscles can work, so we can burn our food for energy. But in insulin resistance, what we actually see is there's an issue with the lock and key on the outside of the cell, so they become jammed. So if we go back a slide, as the blood sugar rises, the body's going to make more and more copies of this key. But of course, if you have an issue with the lock on your door, making 100 keys at Walmart is not going to help you open it. Now, why does the body just keep creating keys, keep creating keys? Why does the body just keep making insulin? It's a defense mechanism. The damaging effects of having elevated blood sugar, it damages the kidneys, the eyes, the nerves. All of our organ systems can become damaged if we have the detrimental impact of inflammation and high blood sugar. So this is a protective mechanism. The body says, okay, we have high insulin. What is plan B? Let's take the sugar out of the bloodstream, divert it into storage. So we see increased weight gain. We can see elevations in triglycerides. We're storing the sugar in the liver. And then this is really the light bulb moment for patients. And I can say, and you can see here, your cells are not getting the glucose. That's why you're having such cravings. That's why you're hungry all the time. That's why you can't think straight. That's why you're so fatigued. So I find this explanation really helpful to individuals. When we look at the impacts of insulin resistance in females and insulin resistance in males, insulin resistance absolutely impacts your hormones. We can see that high levels of insulin, hyperinsulinemia, creates changes in the cholesterol. We see in the liver reductions in sex hormone binding globulin, increasing the free testosterone. At the levels of the ovary, we see an upregulation of DHEA. So when I'm talking with patients with PCOS or acne or elevated androgens, I am showing them this to help them understand why they're either being prescribed berberine or why their doctor is talking to them about metformin. And yes, for elevated androgens, we can talk about things that reduce the free testosterone, Solplamento, spironolactone's the medication that's often used. But when you show this to an individual and say, okay, we want to fix your symptoms by addressing the androgens, but we also want to take a look at the insulin resistance that's underneath, because that is what's driving up the free androgens. And I feel that this is a really light bulb moment when patients see this. In males, it's a little bit different. So in males, insulin resistance does not lead to elevated testosterone. We actually see the opposite occurring. Insulin resistance creates more pro-inflammatory cytokines. Growth of the adipose tissue releases those cytokines, sends a downstream effect to the brain. Leptin causes issues with reductions in testosterone. We also know that the presence of more adipose tissue will upregulate the aromatase enzyme, which will convert the testosterone to the estradiol. So we're not seeing the same effects in males. And for males with low testosterone, which we're going to cover, it's a little bit of a chicken of the egg analogy. Is it the low testosterone that's causing more insulin resistance, or is the insulin resistance that came first? And that differs a little bit depending on the patient case. Lab assessment for insulin resistance. Yes, fasting glucose. Yes, hemoglobin A1C, your average blood sugar over 3 months' time. But a fasting insulin is really important. You could also run a HSCRP or CRP to look at levels of inflammation. You could address liver fibrosis by having a look at a FIB4 score, liver enzymes. And for patients where you're unsure if the fasting insulin is normal and the fasting glucose is normal, you could also run a 2-hour glucose insulin tolerance test where you're administering 75 grams of glucose and monitoring the glucose and the insulin over time to see how the body responds in real time. Now, my patients like testing. I like testing, especially for monitoring purposes, although any individual that has a BMI that's quite elevated, that is strongly associated with insulin resistance, so keep that in mind. Other labs for insulin resistance would be a full thyroid panel, cortisol, prolactin, vitamin D and other nutritional deficiencies, a hormone panel, HSCRP. You could also run a leptin. Sometimes with the costs, I take the leptin off because most times when I see insulin resistance, I know that the leptin resistance is going to come with it. Now, I mentioned nutrient deficiencies. Why are we looking for nutrient deficiencies in patients with insulin resistance? Well, we know that altered levels of things like zinc, cobalt, magnesium, iron, vitamin D, selenium, this creates oxidative stress and can predispose an individual to the development of insulin resistance and type 2 diabetes. I find that this was a really interesting study. And again, these are slides that I'm showing patients in my practice. This is why I want to test your iron. Deficiency in iron can actually impair glucose metabolism. We know that deficiencies in zinc, the same thing. Many studies on vitamin D, there's an association there with insulin resistance. This is why diet is so important, not necessarily from the only one size fits all that's going to correct your insulin resistance. But if you're deficient in these key nutrients, it could be making it worse for you. Now, for individuals who are coming to my practice who have a really poor sense of what their nutrition should look like, getting them on metabolic synergy is a really great option. Now, metabolic synergy, I think of as the multivitamin designed to help individuals with insulin resistance and blood sugar concerns. It's a multivitamin plus a chromium, plus antioxidant support, plus a B complex, all into one. Now, the interesting thing with this product in particular is it has 100 milligrams of R-lipoic acid specifically. R-lipoic acid combined with biotin has been shown together to aid in insulin secretion and glucose metabolism. Now, the standalone R-lipoic acid does not contain any of the S isomer. So back to organic chemistry. Now, the reason you don't want that S isomer is because it competes for the docking site on the mitochondrial and has an inhibitory effect rather than stimulatory actions. So maybe the dose of lipoic acid on the bottle can look really fancy and really high, but if it is primarily that S isotype, you are not going to get as much therapeutic benefit from it. This is the complete nutritional support for energy production through glycolysis and the Krebs cycle. So this is really designed for individuals who really need to get their nutrition in check. Yes, we're going to work on the nutrition piece, but this is an overall good multivitamin for them. Now, why is iron a big deal? I see so many cases of iron deficiency anemia. Iron is required for your thyroid hormone. It's required for converting the amino acid tyrosine to dopamine, your motivation hormone. Of course, it carries oxygen around the body, so it's important for your energy. If you're low energy, you're brain fogged, you don't have motivation, it's going to be really hard to get back on track with your diet and lifestyle. Now, iron deficiency has been shown to impair glucose metabolism, increasing the risk of insulin resistance and type 2 diabetes. We also know high iron has the same effect. So it really is that Goldilocks one where you want to get it in the right range. Here's an example of blood work. This patient had a fasting glucose of 6, technically within the normal range, hemoglobin A1C of 5.6 in that at-risk category of prediabetes. From my experience, conventional medicine would say, yeah, you're fine. Everything's good, eat less, move more. We'll see you in a year. Now, I ran the fasting insulin. Look at how high the fasting insulin is, 221. A fasting insulin of 221, this individual is going to really struggle with weight loss until that insulin gets under control. And this is why I do the baseline and show individuals follow-up testing. Until that fasting insulin gets into the optimal range, it's really hard to lose weight. I have patients, I don't know if it was this one in particular, but their starting insulin is so high, then we get them down to 100, but they're still not losing weight. They're frustrated, they're upset. And I'm like, look, your insulin's been cut more than 50%. This is really great. You're going to start to see results now. Is this something that you're willing to continue for another 3 to 6 months? And I have so many patients that just stick with it. And by the time they come back, we're seeing really favorable results. In terms of the lipid panel, the triglycerides are a little bit higher than I want to see them. I see them at 0.8 as optimal. The HDL cholesterol, I want to see that well above 1.3. So we're seeing signs of metabolic syndrome here, even though the LDL is normal. I also run inflammatory cytokines. So the CRP is elevated. I like to see this less than 1. Inflammation increases the expression of several proteins that suppress insulin signaling. So if you have inflammation, your blood sugar is not going to be as well controlled. Thyroid panel looked fine, no concerns there, but the sex hormone binding globulin, it's on the lower end. So we need to think of, why is this? Is the thyroid okay? Yes, I think the thyroid's okay. Is there high cortisol? Is there insulin resistance? Those are all reasons why the sex hormone binding globulin will be lower. And we can see fluid retention in this, acne, increased appetite, weight gain, mood swings. So explaining this to patients can be really empowering. Vitamin D, really, really important to maintain your blood sugar. There is a strong connection between insulin resistance or vitamin D deficiency as a risk factor for metabolic syndrome and type 2 diabetes. So this is too low. You want to make sure that you're doing repeat testing to ensure that your dosaging is working as well. Here's the 2-hour oral glucose tolerance test. So this is the test you have patients go in. If their fasting insulin is normal and you're curious to get a little bit more information, you could run this. Now, if the fasting insulin is normal and they have a really, really high BMI, their triglyceride to HDL ratio is elevated, I'm like, I don't need this test. I know you have insulin resistance, but I have some patients that are like, I want to do this. So we do this and we have a look at how the blood sugar and insulin changes after every 30 minutes. Now, the other thing I put a note down here, if you already have a fasting insulin and you want to save the patient some time, some practitioners think this is great and other thinks it's terrible for saying this, but instead of having them drink the 75-gram glucose drink, you can have them go to McDonald's, get a pancake breakfast with a small orange juice, all of the syrup, no butter, and you can have them have that all, and then 30 minutes later start their testing. So they actually don't need to do the full test. Now you have to interpret it properly based off of the test results that come back if you have a patient that does that. Now, what are some of the strategies I use for insulin resistance? I'm a big fan of intermittent fasting. It increases beta hydroxybutyrate levels, which are ketones, after about 12 hours. We see reductions in blood glucose. We see reductions in inflammatory meters. In the muscle, we see increased insulin sensitivity, reduced inflammation. In the liver, we see increased insulin sensitivity, ketone productions, reductions in inflammation. In the intestines, we see reduced energy uptake. We see reduced inflammation, brain, heart. If you're having individuals doing longer fasts, greater than usually 72 hours, then we can start to see the upregulation of autophagy. In terms of the research on intermittent fasting, this study here, 16 weeks, 10 to 12 hours of restriction in overweight and obese individuals. Body weight was reduced by 3.5%. In another study, 8-hour time restriction over 12 weeks in obese individuals, overweight individuals. We saw 5.2% reduction in body weight. But the thing here that I think is really interesting to highlight is those that did not sleep well only saw a 2% reduction. So it's the holistic approach, making sure your patients are not only doing the intermittent fasting, but also working on their sleep. In terms of the research, this study compared 3 meals a day versus skipping breakfast or skipping dinner. And what they found is that the fasting leads to lipolysis, which is the breakdown of fat and increased energy expenditure. Obviously, when you're fasting, your 24-hour insulin is going to drop down. Lower amounts of insulin allows for lipolysis, which is the breakdown of fat. We see significant increase in 24-hour energy expenditure. So we're actually seeing many improvements in overall metabolism when done correctly for the right reasons in the right individuals. Now you can imagine if you have a patient that's eating 6 mini meals throughout the day, every time they're eating that, especially if it's higher carbohydrates or they're snacking all the time, they are constantly elevating their insulin, not allowing enough time for the insulin to come down. The question I get asked with fasting is protein broken down? And the thing is, lean individuals will derive 40% of their energy from protein during a fast. That's not good. So if you have an individual who wants to lose, they're already in a healthy BMI, but they want to lose 5-10 pounds, something like that, it's really, really important to explain this to them and supplement with amino acids. I feel that preserving lean muscle is so important that I do it in both ways. I do it in capsule form and I do it in powder form, because if they're going to miss one, then at least they get the other. Whereas individuals who are obese or they do have weight to lose, the good news is while they have the weight to lose, they're going to derive primarily their energy source not through protein. So for individuals who have lots of body weight, they're more protected, but as they get leaner and leaner, you want to start by adding in some amino acid supplements. What breaks a fast? Anything that raises insulin is going to break a fast. So if somebody is insistent that they have to have some sort of cream to change the color of their coffee, fine, keep it under 50 calories. Green tea, black coffee, water is all great. I often recommend glucose monitors to individuals in my practice. There's a couple key things that I don't love about this reader. I love that it's convenient. They can just go to Shoppers Drug Mart or pharmacy and get it. I don't love how pressure can create changes to the readings. So if somebody sleeps on their left side, you want to make sure to tell them that it's on the right. I find that sometimes this can create a lot of stress for individuals when they're constantly checking it. So this is really about monitoring trends, and it's really about learning over a 2-week period for individuals. When I recommend this to individuals, I will give them a cheat sheet. This is what I want your fasting to be. This is what I want your 1 hour after a meal to be. This is what I want your 2 hours after a meal to be. I'm not so caught up on the numbers. I'm more concerned with the trends, right? So did you not sleep? How did your blood sugar respond the night before? Did you have alcohol? How did your blood sugar respond before? Did you exercise? How did your blood sugar respond the 24, 48 hours after? So it's more of a learning tool for trends. Additional support for insulin resistance. So if an individual is on really good, healthy whole food nutrition, they don't have nutrient deficiencies, you don't feel like they need a supplement for their microminerals and antioxidants and things like that, one of my next favorites is berberine. Berberine has been shown in many head-to-head comparative trials to metformin to be equally as effective at lowering fasting blood sugar, reducing the hemoglobin A1C, lowering LDL cholesterol, triglycerides, and lowering the fasting insulin. And this study I often pull up because I don't know what it was with berberine that individuals are worried about it negatively impacting the liver function. I don't know if it was an adulterated product of some sort, but in a rat study where they were fed a fatty liver inducing diet, so a diet to induce fatty liver, berberine reduced their total body weight, their abdominal weight, their cholesterol, the triglycerides, and it also reduced the serum AST and ALT, so the liver enzymes, suggesting a protective benefit. Now, the berberine specifically, we know berberine is a large molecule. We know that it's hard to absorb. And large molecules that are hard to absorb, that are also antimicrobial, can cause some digestive upset. Now, this product in particular is in the Avail technology. So it's emulsified, it's better absorbed, usually less side effects for individuals, but I do still warn individuals that it may upset the stomach initially as it is shifting the gut microbiome. Research dosages on berberine are anywhere from 1 to 2 grams a day. There is 400 milligrams of berberine in the Berbavel, but I equate this to 500 milligrams because of the absorption rate of it. Berberine lowers fasting glucose, lowers fasting insulin, increases insulin sensitivity, and it upregulates the insulin receptor expression. So this is what I really like about berberine is it's getting to the root cause by changing the receptor expression. It's not just a carb blocker where it's blocking the absorptions of carbohydrates or causing diarrhea or changing the way that your tongue tastes sugar like gymnema. It really is working on the root cause. And again, research dosing 1 to 2 grams a day. We talked about it, getting to the root cause, changing the insulin receptor expression. Now, berberine also has some interesting ways that it modulates the gut microbiome. So it's antimicrobial. And because of these antimicrobial actions and the way that it shifts the gut microbiome, this may be in part why it has the favorable benefit on blood sugar. So we see that there is increase in short chain fatty acid producing bacteria. We also see increased levels of Akkermansia muciniphila, a really important bacteria for weight management. And we also see that berberine reduces specifically gram-negative bacteria, which can reduce the LPX toxins and increasing the short chain fatty acids at the same time, which I find quite fascinating. Segueing into gut health. We know that the gut microbiome is playing a role in weight management. And this is relatively new research. I think it's one of my favorite things to research because it's so interesting that the gut microbiome can play a role in your weight. Now, on the left-hand side here, you see 2 rats. These are actually genetically identical rats. One's obese, one's lean. And the researchers wanted to understand why is that? So they looked at the gut microbiome and they actually saw key differences. They saw key differences in Clostridia levels, key differences in the Firmicutes bacteroides ratio, and key differences in Akkermansia levels, which we're going to talk about in a second. Then what the researchers did, and they said, okay, let's take the feces from the obese rat, transfer it into the lean rat, and see what would happen. That lean rat actually started to gain weight, and we've repeated this in human studies as well. So we're starting to understand that it's not simply the foods that we eat that dictates our blood glucose or insulin levels, but the bacteria also play a really important role. And the nature of the gut bacteria can actually dictate how much your blood sugar spikes after a meal. We also know that our gut bacteria can influence the amount of glucose that we are absorbing from a meal. And we see this difference in blood sugar spike in the identical twin studies. Recent research suggests that improving the levels of the gut flora will support and improve insulin resistance. Research suggests that supporting and improving levels of the gut microbiome will support and improve insulin resistance. And we see this both with berberine and metformin. So both berberine and metformin, yes, they can reduce the blood sugar. Yes, they change the insulin resistance receptor expression, but they also both modulate the gut microbiome. We also know that individuals who are more prone to obesity tend to have less diversity. Now, is this less diversity contributing to the weight gain, or is it the fact that they're not consuming a variety of fibers that's leading to the diversity, chicken or the egg analogy here? Interestingly enough, metformin, the pharmaceutical drug we use for the individuals with type 2 diabetes, increases akkermansia, and so does berberine. And when we talk about akkermansia mucinophila means mucus loving. So akkermansia really loves mucin, and it degrades the mucin in the gut. And this is really important because when akkermansia degrades the mucin, it creates byproducts for other bacteria to use to produce short-chain fatty acids, such as fecal Calibacterium prasinitsky is a really important one. And what we know from the literature is low levels of akkermansia is associated with more obesity, more diabetes, more inflammation, and more metabolic disorders. So we need to be supporting this bacteria. How do we increase it? We want to consider bifidobacterium probiotics. We want to consider resistant starch, glucomannan fiber, antioxidants, anti-inflammatories, berberine, because we know akkermansia does not thrive in an inflamed gut. So reducing inflammation is going to be important. Of course, reducing alcohol consumption, processed foods. This says avoid a high-fat diet. Now, when they're talking about a high-fat diet, we're not saying healthy fats. We're talking about cake, donuts, cookies, things like that, deep fried foods, French fries. Now, the other thing that I find is individuals who have elevated steatocrit on the GI map, showing that they're having increased fat present in the stool, they commonly have low akkermansia. So one of the things is, it's not necessarily that you need to be on a low-fat diet by any means, but we need to make sure that the healthy fats that you are eating are actually being digested and absorbed. Here's an example of a GI map test, which we're seeing. There's low levels of akkermansia, where she's also experiencing weight gain. Because there's low levels of akkermansia, the fecal Calibacterium prasinitsky is not thriving, and that's a key butyrate producer, which is important for the health of the intestinal cells. We're also seeing that the FB ratio, the Firmicutes Bacteroides ratio, is really high, like really high. So there definitely is an imbalance here that we need to consider. Now, if you have a high Firmicutes Bacteroides ratio, you want to look at diet. Are they digesting their fats properly? Do they need digestive enzymes or betaine HCl? So check the elastase levels on the GI map. You want to use bifidobacterium probiotics or the Floromyces, the Saccharomyces boulardii specifically at 2 caps a day. I did want to touch on the ProBiomed 50 because if a patient has normal FB ratio, this could be a really good probiotic to consider. Specifically, this contains Bifidobacterium breve, which helps to maintain fasting glucose, decreases HSCRP, and increases plasma glutathione. Bifidobacterium longum, studies have shown that it can reduce TNF-alpha, an inflammatory cytokine, CRP, serum AST, a liver enzyme, and help with insulin resistance. The other thing to mention with GI map testing, if you're seeing elevated beta-glucuronidase, this is causing estrogen recycling. It can interfere with phase 2 detoxification involving glucuronidation. I've also listed here all of the key bacteria. It's the bacteria that's producing the beta-glucuronidase. So treating the bacterial overgrowth is important, but oral supplementation of calcium D-glucarate has been shown to inhibit beta-glucuronidase activity. Section 3, liver health. The liver is so important for blood detoxification, regulation of bile and blood sugar. It's important for the storage of vitamins and minerals. It's important for cholesterol management, and of course, hormone metabolism and production. Non-alcoholic fatty liver disease is incredibly prevalent. It has a high prevalence of 40 to 75%. Here's the blood work that you could consider. And we also know that it's insulin resistance with poor gut health that leads to the development of fatty liver disease, non-alcoholic fatty liver disease. Now, for whatever reason, patients seem to be way more concerned about their fatty liver than their insulin resistance. So if this is something that you can screen patients for and diagnose them for, it almost is a little bit of like a fire, like a flame that ignites in them. They're like, well, my liver is fatty. I really need to now get this under control. Importance of the liver, if you do have a patient with non-alcoholic fatty liver disease, address the inflammation and gut dysbiosis, address the insulin resistance. Annatto-E, delta tocotrienols, has some really favorable research on it in patients with non-alcoholic fatty liver disease. First study was a randomized controlled trial, 71 NAFLD patients, 12-week supplementation. We saw a 15 to 16% reduction in ALT and AST. We saw 11% reduction in triglycerides 18% reduction in CRP. We also see 24-week studies, 120 patients with type 2 diabetes receiving 250 milligrams. We saw reductions in hemoglobin A1C, hsCRP, TNF-alpha, reducing fasting insulin. So this is definitely something to consider if there's non-alcoholic fatty liver disease. High cholesterol is a great one to consider it, as well as insulin resistance. Estrogen dominance. Common conditions associated with estrogen dominance. We can see weight loss resistance if the estrogen is too high or if the ratio between the estrogen and progesterone is too great. Of course, this is a common pattern that we see in PCOS and estrogen-dependent cancers. We can see this in endometriosis patients, as well as patients with irregular menstrual cycles. When it comes to estrogen, we want to think about production. Is this a premenopausal woman where the primary production is coming from the ovaries? Or is this a postmenopausal woman where the primary production is coming from the fat tissues and the adrenal glands? Is the estrogen coming from the aromatization from testosterone? Is there environmental estrogens? And we also need to consider how estrogen is detoxified. We need to understand the detoxification process because each metabolite of estrogen conveys different impact. So if you're running Dutch tests, you can see the metabolites through phase 1, detoxification, the 4-OH, the 2-OH, and the 16-OH. We want to be going down that 2-OH pathway. This is more protective. You can push this pathway by considering things like DIM. If a patient's going down primarily that 4-OH pathway, this is not good. This forms quinone adducts, which can damage DNA, increase the risk of estrogen-dependent cancers. Things like NAC and glutathione you might want to consider here. If a patient is heavily going down that 16-OH pathway, this is significantly estrogenic. I call this the miracle grow for estrogen-dependent tissues, so weight gain in the breast, the hips, the lower half. Here you could consider sulforaphane. When it comes to detoxification, there's phase 1 and phase 2 for a quick recap. Most individuals that I see with resistant weight loss, they do fine with their phase 1, they form the reactive media, and they're really slow on the phase 2. So what I'm often considering doing is still support the phase 1, but really support the phase 2 for the elimination of those interactive mediators. My favorite products for detoxification are the detox support packs, and I hope we get those back. So Designs for Health used to have these really great packs. They're in blister packs, easy to peel off. The supplements were all there, super for compliance. Now what we need to do is we need to take the bottles and deliver the bottles, is what it is. So the liver gallbladder complex helps to keep the bile flowing smoothly and efficiently. The detox antioxidant is going to support phase 1 and phase 2, and the amino detox is really going to help not only with providing the patients with the amino acids to protect their lean muscle while still supplementing with the amino acid supreme, but also really pushing phase 2. I've put in the blue box the replacement for the detox packs. You need 1 bottle of the liver gallbladder, 1 bottle of the detox antioxidant, and 2 of the amino detox. They will have extra liver gallbladder complex. I mentioned sulforaphane previously. I find sulforaphane really, really interesting. It's really important that your patients are consuming vegetables. How many individuals are not even consuming a single vegetable in a week? We want individuals to be consuming an abundance of sulforaphane-rich vegetables at least once, ideally 2-3 times a day. A 2017 study in mice showed that mice fed with sulforaphane gained weight at a 15% lower rate. We also see that sulforaphane has the ability to reduce bacterial species in the gut that are overproducing those inflammatory LPS toxins. Brocco Protect had the added myrosinase from the mustard seed that helps to convert it to the active sulforaphane, the glucoraphanin. And Brocco Protect does not contain goitrogens, so they will not block the uptake of iodine by the thyroid, and it only contains 1.5 micrograms of vitamin K, which is equivalent to a potato. So it makes the product acceptable for individuals on blood thinners. Now, what about menopause? We talked about too much estrogen. What about not enough estrogen? Estrogen is another one of those, you need to have it in the right amount, hormones. Cardiovascular disease is the leading cause of death in women worldwide. It accounts for 45% of total mortality, whereas breast cancer is only 5%. We know that the risk of developing cardiovascular disease increases after menopause. We see increased body fat. Like, how many patients go through menopause and they're like, I'm not doing anything different and I'm gaining weight? That's because there's a reduction in insulin sensitivity. There's an increased risk of type 2 diabetes. There is an increase in blood pressure that we see, increase in triglycerides, and many women with premature ovarian failure, so going through menopause prior to the age of 40, have a significant increased risk of cardiovascular disease. This was a small study. It was 40 postmenopausal women with type 2 diabetes. They were enrolled for 12 months. Half of them were assigned to take HRT, while the other half was in the control group. The HRT group was significantly associated with a decreased HOMO-IR, so marker of insulin resistance, and fasting blood sugar. So HRT was associated with statistically significant increased insulin sensitivity. And I feel that HRT could be a whole other presentation to cover, so we're just going to leave it at that for today. Now, what about low testosterone in men? We do know that there's a link between testosterone deficiency and diabetes. Chicken or the egg? Is it the low testosterone creating the insulin resistance, creating an issue with impaired mitochondrial function? Or is it the insulin resistance and the inflammation that comes with it, and the leptin and the aromatization? Is that what resulting in the insulin resistance? Now, it depends on the patient. If a patient is not in a place to use testosterone replacement therapy, maybe they're high risk cardiovascular disease, you really need to get their cholesterol under control before you consider TRT, then maybe working on the insulin resistance and seeing how the testosterone responds is your approach. And then I have other practitioners that I work with in terms of nurse practitioners where they start patients if the testosterone's really low on a low dose of TRT because the patient really wants it. And it creates such a positive benefit in their mental health and their motivation and their energy that then that helps to fix with the insulin resistance. Mindset and stress. We all know this, stress impacts every single body system, whether it's the GI tract, weight gain, fatigue, acid reflux, libido. Stress impacts what we eat, how we digest, how we assimilate and absorb those nutrients, and how we eliminate. If we have abnormal levels of cortisol, it's catabolic. Cortisol breaks down your lean muscle mass. Lean muscle is so important for managing your blood sugar. High cortisol, we see weight gain around the midsection. We see reductions in secretory IgA, the immune system in the gut. We see inflammation. We see reductions in serotonin, the happy hormone, and reduced resiliency to stress. So this cannot be a missing piece with your patients. Stress will cause glycogen, stored sugar, raises the blood sugar. So glycogen is broken down, raises the blood sugar. We see that bone starts to be broken down for sources of calcium, magnesium. Glutamine from the muscle is converted to glucose. So again, supplementing with amino acids for patients who are stressed. Chronic stress response gone too far, diabetes, cardiovascular disease, high blood pressure, GI illness, autoimmune diseases. You guys all know this. There are glucocorticoid or cortisol receptors found everywhere throughout the body. Non-negotiable, 5-minute journal, psychotherapy, gratitude, yoga, meditation. Ask your patients every visit, what are you doing to manage your stress? What do you do for fun? What are your hobbies? So many of them need help figuring out what they like to do for fun. Designs for Health has a ton of products for the adrenal glands, adrenatone, herbal-based product, B5, B6. Of course, the C+ Biofizz is my favorite because it also has the quercetin and nettles in it for some anti-inflammatory, great for allergy season that's coming right up. Magnesium, your B Supreme, but also remember amino acids, amino acids, amino acids. Lack of sleep is a stressor. If you're not sleeping, you're driving down your satiety hormone, your leptin, you're increasing your ghrelin, your appetite's going to go up. If you're not sleeping, you're going to have cortisol dysregulation, you're going to have inflammation. You need to make sure that you are supporting your patients with their sleep. The Insomnital chewables are great, magnesium L-threonate, the catechol can really help patients. Sometimes with sleep, it comes down to getting the blood sugar under control, improving hormone-related health, and trying out different products to find which one is going to stick. We have to remember that diet is a stressor. Remove the processed foods, remove sugars, remove alcohol, stop eating inflammatory oils and seed oils. Talk to your patients about what those are. Stop heating the oils. This is exactly the nutrition framework that I follow with individuals. An anti-inflammatory diet. I keep it simple, 4, 4, 4, 4, 4. 4 ounces of protein, 4 ounces of cruciferous vegetables, 4 ounces of fruit, unlimited water type vegetables, space your meals 4 hours apart. People need simple, they need an exact plan to follow. Would this be fine at 5, 5, 5? Of course, it would be fine, go for it. I just chose 4, to be honest. Most of my patients are significantly overweight. That 4 to 6 ounces of protein is great. Modify this based off of what you find success with your own patients. Here's an example of some meals. Easy peasy whole food nutrition. Eliminate artificial sweeteners. Don't talk about Diet Coke on Instagram or TikTok. People get really, really offended about it. Yes, there is a dose-dependent nature to this, but both human and rodent studies have demonstrated that sucralose may alter glucose, insulin, and GLP-1 levels. It may damage the microbial diversity. It does depend on the volume in which patients are eating, but I've got some patients that can down a liter or two of Diet Coke every single day because they're trying to follow a carb-free diet. So recommend things like xylitol, stevia, monk fruit sweeteners. When it comes to exercise, I think resistance training is wonderful. I really, really like resistance training. But for patients who have insulin resistance and they are so far gone, that sounds terrible. They need so much help. I always say, let's focus on nutrition first and let's add in the exercise after, because we have to remember that over-exercising will increase cortisol. It's more demand on the body. It will increase your appetite. Patients can do walking, Pilates, yoga, low intensity resistance training, but be mindful, the more weight you lift, if you're already struggling with your appetite, the more that exercise is going to increase your appetite. Thyroid. Quick note on thyroid testing. You need to test first thing in the morning. You need to test fasted. Tell your patient to avoid biotin at least 2 days before, and then know when your patients are going if they're on a T3-based medication. It doesn't matter so much for a T4-based medication, but if they are taking T3, liothyronine, or cytomel, know when they took it. Are they taking it before or after? Are you measuring their top T3 levels? Are you measuring the peak or the valley? Keep in mind that estrogen levels can influence thyroid hormone as well. High levels of estrogen can increase thyroxine binding globulin, a protein that binds onto the thyroid hormones, resulting in decreased levels of the free hormones. This study I found really interesting. It's stuck with me ever since I saw it. TSH can be significantly higher in the morning compared to the afternoon. So this one particular study showed that 50% of patients in the study would not have been diagnosed with hypothyroidism had they been tested in the afternoon. This is a new product, Thyroid Norm by Designs for Health. It's actually a really great product, and it has 2 ingredients. It has myo-inositol and selenium. Now, we know that selenium is really important for converting the inactive thyroid hormone T4 to the active T3, but selenium also exhibits the behavior to support the removal of reactive oxidative species. The thyroid gland is particularly vulnerable to oxidative damage, so that's another way that selenium can support. We know that in clinical studies, supplementation with selenium may decrease thyroid antibodies that are associated with autoimmune thyroiditis. One study of 88 individuals over 9 months, we saw that the selenium methionine reduced the thyroid antibodies by 26.6% after 3 months' time. So this is really important to note. Your patients are not going to take 1 bottle and then you're going to repeat right away to see a reduction in the thyroid antibodies. You do need to wait the 3 to 6 months and educate patients that this is a long-term supplementation that they would be on. Now, when it comes to the addition of myo-inositol, why is the myo-inositol in there? Well, we do have studies comparing selenium alone versus selenium and myo-inositol for, again, 6 months' time. So keep the duration at play or keep it in mind. The myo-inositol selenium group experienced a 31% reduction in TSH, 44% decrease in TPO antibodies, and 31% reduction in thyroglobulin antibodies. Where the selenium-only group, there still was reduction in the thyroid antibodies, but it didn't change the TSH. Now, the question is, well, why is that? Well, we know, back to insulin resistance, we know that there's an association between insulin resistance and Hashimoto's. Insulin resistance and thyroid antibodies have an association together. And the mechanism of action may be that there is the production of the pro-inflammatory cytokines from the insulin resistance, which may activate the complement pathway and ultimately the T cells, leading to an increase in these thyroid antibodies. So the key here is selenium plus myo-inositol to reduce the antibodies to TSH and the insulin resistance, because it's a really great dose of inositol. Genetics. How genetics can impact the weight. For individuals who do genetic testing, you're going to find this interesting. If you don't, you might want to consider it. You still might find the information interesting, but I'm going to highlight the key things that I would look at on genetic testing. Genetics can influence your weight by your mood and concentration, so dopamine and serotonin. Genetics influence detoxification, estrogen metabolism, which diet would be best for each individual, exercise. Then we're going to talk about the FTO gene. So for patients who make less dopamine and they clear out the dopamine quickly, they're the ones that are scrolling on the TikTok all night long or Instagram. Go, 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 go. They have a greater desire for fattier foods, chips, cheese, nuts, alcohol. These are the patients that you need to get them moving. You need to do jumping jacks when you're feeling that food craving. Go for a walk, distract yourself. You could also consider green tea, L-tyrosine, rhodiola, and magnesium. But the key with dopamine issues is the exercise. For individuals who make less serotonin, there is a really interesting connection between low serotonin levels and, of course, depression, but also waking up early in the morning, having GI symptoms, bloating, irregular bowel movements, muscle pain and swelling, and food cravings, specifically chocolates or sweets. Doing a higher dose of 5-HTP, especially in patients who are having the symptoms of depression and low mood, could be quite helpful. Recommendations for detox. Patients with a fast phase 1, they're producing a lot of that reactive intermediate. You may want to slow that down. A great way to slow it down is with coffee, and curcumin will actually slow down phase 1. Now, for patients with a fast phase 1, it's also really important to support phase 2. Or for patients with a slow phase 2, doing things like the N-acetylcysteine, liposomal glutathione could also be a factor here, as well as amino acids, amino detox. Estrogen metabolism. If an individual has a poor conversion to 2-OH, right, they're producing more of the 4-OH, the potentially carcinogenic estrogen, the 16-OH, the Miracle-Gro estrogen, as I call it. You want to support moving them more down that 2-OH pathway with the Dimavale, with the Bronchoprotect. What is the FTO gene? The FTO gene, or the fast mass and obesity-related gene, was the very first gene that was identified and linked to its clinical implications of obesity. Approximately 42% of Caucasians, 5% of Africans, and 20% of Asians carry the risk allele. So this is incredibly common. Now, this does account for an overall increased risk of obesity by 22%. However, the effects are significantly worse if an FTO-A individual consumes a low-protein, high-saturated fat diet or high-calorie diet. This is where nutrition becomes really important. For an individual that has the A allele, they also have issues with their hunger and satiety cues. So they have issues with adiponectin, ghrelin, leptin. Endotrim could be something to consider if you're specifically seeing that, if they're really, really struggling with their hunger and appetite, but also make sure that they're getting enough protein, they're not on a high saturated fat diet. Other ways for hunger and satiety: intermittent fasting, amino acids, sleeping, high protein, high fiber, reductions in the saturated fats, refined carbohydrates, sauna, exercise, eliminate the artificial sweeteners, check vitamin D levels. We actually know that individuals with the FTO gene variant are less likely to have weight gain as long as their vitamin D is okay, and perhaps limit dairy. In this section, we're going to talk about some of the common medications. This is where we're going to go into some of the information on the GLP-1s. I do not prescribe medications. I do not have a license to prescribe medications. This is not medical advice. This is resources directly from the medication handout and things that I would review with individuals in my practice. Keep in mind, my practice, I work hand in hand with nurse practitioners, and I also have a lot of patients who are coming in on these medications, so I find this information could be quite helpful. Metformin, how does it work? It's, of course, one of the medications that's used for individuals with type 2 diabetes. It's been shown to increase GLP-1, lowering blood sugar, helps with appetite, reduces liver sugar production, does help with insulin resistance. Metformin reduces insulin resistance, thus insulin, and in PCOS patients, it's commonly prescribed. As we saw previously, the less insulin resistance, the less androgen production. Now, problems with metformin, we know that both short-term and long-term use, metformin can deplete B12. There's a great website called mytavin.com. You can have patients just type in their medications. They can see for themselves what nutrients they deplete. Designs for Health is a great handout too, drug-induced nutrient deficiencies and the supplements to consider. Individuals who are on metformin greater than 6 months, we see reductions in certain cobalamin levels. I like the tricobalamin. It's 3 different forms of vitamin B12. If a patient's on metformin long-term, we can monitor their levels, and they usually supplement 2 to 3 times a week with that. Signs and symptoms of B12 folate deficiency: fatigue, anemia, tingling in hands and feet, mood changes. It's really important patients who take metformin have their B12 levels checked. Metformin is known for GI upset, so consider digestive enzymes. Berberine could be an alternative, although it also has the potential for GI upset. Probiotics may also be helpful here as well. Semaglutide. So what are semaglutides? These are GLP-1 receptor agonists. They help with satiety. They help with reductions in hunger. Name brands: Ozempic, Saxenda, Rebellis. Ozempic is once a week daily injection. Ozempic is once a week injection. Saxenda is a daily injection. Saxenda can be dosed daily at smaller doses and sometimes can help with the side effects. Rebellis is an oral GLP-1. It does not always covered under insurance, and it does seem to cause a lot of GI upset in my experience with patients. They do slow gastric emptying. They do modulate the reward pathways. I've had a lot of patients say, I just don't have cravings for alcohol anymore. I'm not getting that same food noise, which has been really liberating for them. It can enhance lipolysis, and currently with Obesity Canada, they're indicated for patients with a BMI greater than 30 or BMI greater than 7 with one comorbidity, weight-related comorbidity, such as hypertension, type 2 diabetes, dyslipidemia. Elevated insulin doesn't seem to be counting, and PCOS doesn't seem to be counting for a lot of the insurance plans either. These are the contraindications to Ozempic. This is straight from the drug monograph. If you are interested in learning more, I think the drug monographs are a really great resource. So diabetic retinopathy, eye damage, low blood sugar, kidney disease, pancreatitis, thyroid cancer, family history of medullary thyroid cancer, kidney disease, pregnant, breastfeeding, allergy to Ozempic if they know they have it, men too is another one. And really important that individuals understand this. Resources, I find that these resources are really helpful for individuals. My role is to provide individuals with education to make an informed choice on what they feel would be best and support the decision in what they are doing. So Saxenda is a type of semaglutide. It's approved by Health Canada for weight loss. Those are the studies. Ozempic is another type of semaglutide. It is used off-label for weight loss. The reason individuals are often using the Ozempic over the Saxenda is it's easier to do once a week versus daily. There is a YouTube video here if you're interested in seeing on what the pen looks like, how it's administered. There's additional details here, ozempic.com, direct patients to the drug supplier. There's also a Facebook group. Sometimes this works out great for patients to gain information and knowledge. Sometimes it becomes more of a stressor with more information. How Ozempic is usually dosed. Ozempic is usually dosed at 0.25 milligrams once a week, and it's increased every 4 weeks as per the Ozempic drug monograph. There are various different practitioners that use this medication in lower dosages and higher dosages. Again, I'm not prescribing this. I'm not talking about this. I have seen patients do really well on lower doses. Patients can count the clicks on the pen to alter their doses in a little bit of way, but this is just general information if you haven't seen what the pen looks like. What I'm really wanting to cover is more of the general support. So if you have a patient that's coming in on these medications or wanting to use this medication, how do we support them and how do we mitigate the side effects? Metabolic synergy if their diet's not adequate, or a multivitamin, because a lot of these individuals are having a hard time consuming enough foods. Amino acids, amino acids, amino acids. You do not want to lose lean muscle mass. You can supplement with whole body collagen, pure paleo protein to get enough of their protein in. Omega-3s to reduce the inflammation. We know inflammation and insulin resistance go hand in hand. We're going to talk about the importance of digestive enzymes and magnesium. What are the side effects? Here again, from the drug monograph, these are the side effects. Most commonly, nausea, diarrhea, abdominal pain, sometimes vomiting, constipation. I haven't seen that with how it's dosed in my practice. Acid reflux, gastritis, fatigue. Again, I don't think individuals really should be taking high dosages of a medication that's making them feel quite unwell, when the lower doses can work just as well when supported with diet, lifestyle, and key supplementation. So what if a patient has nausea? Hydration, hydration, hydration. You may also want to look at the food volume. If they're consuming a really, really large volume of food, do they need to space that out a little bit? I find digestive enzymes, either the betaine HCl or the digeszymes, work really well because remembering these medications are delaying gastric emptying. Gastromen, 2 caps 3 times a day, and DGL is needed is also really helpful. Liquid B6 and ginger. And sometimes individuals may need to speak with their practitioner about changing where they're doing the injection site. Just as something I've observed, individuals that are injecting in the abdomen, for whatever reason, again, I don't know the science behind it, seem to have more side effects than an individual who's injecting in the leg, but always have them speak with their practitioner. Constipation is one that's really easy to fix with magnesium citrate. Science for Health has one, digestive enzymes. They're not getting enough fiber, paleofiber, Phloromyces. Fatigue is a big one. This is often coming from the fact that they're just not getting enough of the micronutrients. Mitochondrial energy could be a good one to consider here, or the metabolic synergy, electrolyte synergy, preterine energy. Now we're going to go through the weaning phases. Again, I am not weaning patients off of Ozempic. I work with a nurse practitioner hand in hand in my office who's doing the prescribing, and this is the formula that we find works really well together with patients. So step 1, before we even touch the dose, are you sleeping 8 hours a night? Are you drinking 3.5 liters of water? Are you taking an honest look at your stress? Are you journaling? Are you doing all of those things? And are you moving? Are you doing at least 10,000 steps a day, or are you doing resistance training? Usually if a patient is not doing this, we say, go do it and come back and we'll talk about weaning the dose later. There's no need to wean off Ozempic. You can just stop it. But I find that really supporting patients to come off it slowly does help with their anxiety of coming off of the medication and gaining weight, and also does really help to troubleshoot if any problems arise. Okay, this is what the meal structure should look like. This is the exact same as what I showed you before. Are you getting at least 4 to 6 ounces of cooked protein? Are half your plate of vegetables? Do you have unlimited leafy greens? I like individuals to have 1 carb serving. Don't completely remove carbohydrates because it's probably not reasonable for them to sustain it long term. This is what meal 2 looks like. This is what meal 3 looks like. For a visual, this is it. This is what I show them. So that's the writing that they get. This is what they get. Quarter of your plate, 4 to 6 ounces of protein, half your plate of veggies. Your carbs are optional, but they should be half the physical size of your protein, and then you have your healthy fats in there. This is what an actual carb serving looks like. Take a screenshot, send this to individuals. It's not the whole bagel from Tim Hortons. It's a very small amount. The carbs need to be portion controlled. Phase 2, when they're weaning off, and again, we're also running blood work here. So we're making sure that their hemoglobin A1C is good, their lipids are good, their fasting insulin is good. When individuals are gradually weaning off the medication, it's usually happening every 2 to 4 weeks. You want to monitor them for returns in their appetite, returns in their sugar cravings, supplement with amino acids, berberine, paleofiber. All of these things can be really helpful if their appetite and food noise is coming back. And that's the end of the presentation.